National Health Commission COVID-19 Town Hall meeting. The AME Health Commission is led by Bishop Harry T. Wright and Dr. Miriam Burnett, who's the medical director, along with Reverend Natalie Minchin, our executive director. Our goal for this evening is to provide you with information so that you are able to make an informed decision regarding COVID-19 vaccinations and have a better understanding of COVID-19 and its transmission. Please, you're welcome to share this information on your social media platforms. We are also, will be answering questions. Please provide your questions in the chat. Sit back and we hope that you are informed and empowered after this presentation. Thank you.
On behalf of the International Health Commission, we want to express that the opinions, responses, and information shared by the professionals, experts, and the International Health Commission today and during all of our informational webinars do not replace having a conversation with your medical provider. We understand some individuals may not have a medical provider or personal doctor. Therefore, if you have questions, especially regarding the COVID-19 vaccines, you can question the medical personnel that will be administering your vaccines before you receive the vaccines. This is all done to assist you in making an informed decision. The goal of our webinars, town halls, and our amechealth.org website is to provide individuals with information to empower you to make an informed choice regarding all topics presented by the International Health Commission of the AME Church. At this time, I would like to welcome our presiding bishop of the International Health Commission, the Right Reverend Harry C. Wright.
All right. Thank you so very much. As we come this moment, we greet you in the name of our Lord and Savior Jesus Christ. Let us now bow in the word of God. Here we begin. The most powerful God, our creative God, our sustainer, our healer, and our deliverer. We come giving you thanks this day for the Health Commission of the African Methodist Episcopal Church, this international commission. We give you thanks for the leadership. We ask that you continue to bless this commission, bless this work, bless this town hall meeting today. We ask that you will continue to give wisdom and knowledge in the midst of this pandemic, in the midst of this coronavirus. Lord Jesus, please continue to allow vaccines, research, and all the things needed to go forth. As we come this day to share information and to reach out to our communities, we ask for your blessings upon every presentation, upon the effort, upon the technology. Please, Lord, hear our prayers. We know that you're the ultimate healer, and we know that you are in control. And that's why we bow to invoke your presence and to thank you for your blessings. Lord Jesus, we'll always continue to give you the glory and thank you for the gifts that you have imparted to these people, that they will continue to enhance the lives of others. In the precious name of Jesus, we pray. Amen.
All right. Good afternoon. And I think it's afternoon in all the places where we are. I'm Reverend Dr. Avita Fuller, and I'm a virologist on the Health Commission and at the University of Michigan. I am going to do my best to take us through a short presentation to lay the foundation. I'm not sure if that sound's coming from me. But let's see if we can get this hopefully you can see that. So this is an update town hall by the International Health Commission of the African Methodist Episcopal Church, with our goal to give you insights so you can make an informed decision. What we will do is to look at the SARS coronavirus and COVID-19 to give you some background. We will then talk about the COVID-19 vaccines, and then we'll have questions and answers where we hope you can put your questions or here or in the Q&A here. The takeaways, just so you know what we're trying to do and trying to help you to understand, is that pandemics are a part of adaptable nature. Humans and animals and environmental come in contact and things change. This is a picture, an actual photograph of the coronavirus. So I'm going to stop just a minute. Is that technically coming from me? There's no typing here, so all right. So for COVID vaccines, you must make an informed decision. All of the vaccines are 65 to 95% effective in preventing COVID disease. And even for a little while, this is a key tool in the global toolkit to manage COVID-19. And then thirdly, whatever you do about a vaccine, you must make and implement infection prevention, such that includes preventions that include masking, distancing, not gathering, hand washing. All of these are absolutely necessary as we try to break the back of this pandemic. It's recommended that we do not gather, that we do not travel, and that we require, expect, and model the compliance by individuals, families, leaders, colleagues, and others that will help us all work together to get out of this. So, as a foundation, coronaviruses are a large family of viruses that are found in many animals, over 100 different species. We've had coronavirus epidemics before, SARS and MERS, some of you may remember. Now the novel, what was called the novel coronavirus, is named SARS coronavirus 2. We think it originated in bats, and it's a zoonotic transfer like many other virus transfers we've had before. You may recall swine flu or bird flu. And so now this virus leads to COVID-19, a new emerged disease, coronavirus infectious disease. The virus is SARS coronavirus 2. The disease is COVID-19. We've had over 6 coronaviruses to enter into humans, and SARS coronavirus 2 that causes COVID is the 7th. On March 11th, almost a year ago, the World Health Organization declared this a worldwide pandemic. And so we see that it's affected countries all over the world, with some of the highest in the US and Brazil and Europe. This is a picture of a cell that has been infected, and the cell itself would be bigger than my screen. And you see lots and lots of viruses, hundreds, and almost thousands of viruses produced in one cell, one infected cell, such that this virus has now spread throughout the world with over 3 million total deaths and over 133 million confirmed cases from a zoonotic transfer of a virus that's easy to go from human to human by respiratory spread. So what do I mean by respiratory spread? I mean it's airborne. It's not in blood. It's not sexually transmitted. It's not in food. It's in the air. Here's an example. One person back in January traveled from Singapore to France that was not producing symptoms, but was infected and thereby breathing virus into the air. That person stayed in a chalet with 12 other people for 2 to 3 days on a ski trip. Out of that, 21 people exposed to one of these people here ended up with coronavirus subsequently. And you see that here in 3 different countries. So this is a very easy to transmit virus. Here's another example where in a restaurant where the air conditioning system was flowing this way over these 3 tables, one person who was asymptomatically infected was at the restaurant with his family. And at the end of the 2-week period, we found that people at table B and C had become infected, but not D, E, F that were out of the airflow of the room. So eating inside is a major way that coronavirus 2 is spread. It's much better to do this outside than inside. And there's some videos that will be put in the chat. The links will be put in the chat where you can actually see this demonstrated. The point is that this is a very easy to transmit virus. Here are the videos. They will be in the chat. So what happens with the respiratory spread of COVID-19 virus? As we talk or breathe or sing, let alone cough or sneeze, we're putting air droplets into the air. And if we have cells in our nasal passages or our throat that are replicating virus, whether we know it or not, that goes into the air. And anyone within 6 feet or even closer or further away for some things can breathe in the virus into those respiratory droplets into their nose. The virus infects the tissues lining the sinuses and the throat and travels down the windpipe, ultimately getting into our bronchioli. We can also self-inoculate by touching things that these droplets with virus have fallen onto. So doorknobs or common objects, and then touching our eyes, nose, or mouth for self-inoculation. The timeline of exposure is very important. We're told to quarantine for 14 days if we think we might have been exposed. The average time from the initial possible exposure to when symptoms appear, if they appear, is typically about 4 to 5 days, depending on how much virus one encounters. But the reason that coronavirus is so easy to infect is that the shedding of virus happens very shortly, within 2 to 3 days after exposure and infection. So we can be shedding virus pre-symptomatically before the symptoms show up. Or there are people who are subclinical or asymptomatically infected that never have symptoms, but they're shedding virus. So this is very, very important. The symptoms can show up to 14 days after the exposure, which is why the quarantine time is what it is. Once the virus is in the nasal passages, it begins to reproduce on the linings there, or the tissue there, and it typically travels down the bronchi, reproducing on the cells in the upper respiratory tract. The immune system kicks in, along with the virus replication, to lead to COVID-19 symptoms. Interestingly, about 40% of all infections have no symptoms. People don't know they're infected, which is why the CDC asked everyone to mask up if you're around other people. People who have symptoms, about 80% of those people have mild to moderate symptoms. About 20% of them get severe disease, which I'm going to talk about next. The bottom line is that the virus goes down the windpipe into the lungs, and from there can cause pathogenesis or disease. So what does severe COVID-19 look like? Here's an example of an X-ray of clear lungs, and this side shows you the bronchi with open air sacs, which exchange oxygen and CO2 to help us breathe and to feed our organs. The right side shows you an infected lung alveoli, where the infection leads to swelling and mucus clogging of this airflow. Eventually, inflammation sets in because of the immune response, and you end up with very clogged airways where you cannot breathe. Eventually, fluid can develop here, which is called pneumonia. So this is what COVID is. Very difficult breathing. Other organs are affected. It is what is called severe acute respiratory syndrome, or SARS, when the mucous membranes are infected and the air sacs no longer function. This impairs lung function such that we cannot get oxygen into the body. That then begins to deprive other organs of the necessary oxygen, such as the liver, the kidneys, the brain, the heart, and the skin. So it's all due to infection and immune response to that infection. There are a wide range of effects with COVID-19, from very mild, such as pink eye, to loss of smell and taste, to very serious, life-threatening, and even events that lead to death. So brain clogs or strokes, lung clogs, which lead to difficulty in breathing, pulmonary embolisms, microclots, blood clots. The heart can be affected. It can weaken the heart muscle because of lack of oxygen. There can be a racing heart and heart attacks. Kidneys are often damaged. Often people who recover from COVID end up on dialysis. The skin can be affected. People have purple toes or purple fingers. The immune system is impaired. Some folks end up with vomiting and diarrhea. And we've heard a lot about the blood clots in people's organs that affect them. So no one typically gets all of these symptoms, but any one of these can appear in people. With the more severe cases of COVID-19 requiring oxygen and ventilation to make sure that the body can get some oxygen. The outcome of this depends on how well the body can be supported for getting oxygen to the organs. Even people who get mild COVID, who don't have to have oxygen, can have what's now recognized as the long hauler syndrome of COVID-19. And this is where even if you have COVID, you get over it. There are people who have symptoms for 2 and 3 and 4 months after. So a fatigue or headache or brain fog where you just have difficulty thinking, shortness of breath, hard arrhythmias, hypertension, racing pulse, joint pains, insomnia, skin rash, vertigo. These are symptoms that seem to occur, and we really don't know what's going on here. This is a huge area of study, but a number of people who get COVID and get over it still have some symptoms several months after. The other thing that I wanted to point out about the disease, particularly for the AME as an African Methodist Episcopal Church, is that with the US leading the world in the number of actual cases and deaths, over 500,000 deaths, even though now we have 175 million vaccines, which is a good start on reducing all of this, African Americans are disproportionately represented in the number of deaths and the impact of COVID. So I'll just show you a couple examples here. This side shows you the percentage of the population that's African American in North Carolina, Chicago, or Milwaukee County. And this shows you the number of people who died that were African American, or the percentage. So in North Carolina, with 21% African American population, the number of COVID deaths were 38% African American. Or in Chicago, with 32% African American population, the COVID deaths, there were 67%. And this is early data from May. And you see that's true in other places. And this just looks at the race and ethnicity of cases, Latinx, Black, white, Asian, or other. And you see Black cases of people who were Black in Chicago with COVID are higher, and consequently the deaths are higher. So we are disproportionately affected by coronavirus and COVID-19. Why? Because of socioeconomic factors, frontline jobs, underlying medical conditions, access or lack thereof of access or difficulty in accessing medical and health care, misinformation that we find on Facebook and that we share with one another, responsible leadership, and other reasons. And the question is, what can we do about these? And the other reasons include the historical, institutional, and systematic racism in the USA. This is another whole topic that maybe we'll have time to do at another time. So now that we see what the disease is, what we're trying to prevent, what we're trying to get out of by stopping the spread of the virus, let's look at one of the tools in our toolkit to stop spread of coronavirus, and that's the COVID-19 vaccines. What's in the vial? So first of all, let me tell you a little bit about vaccines. We want you to understand that vaccines prime the wonderfully made immune system that's a part of the body. They do not cause actual disease. We have many successful vaccines that most of us have gotten. We don't get smallpox anymore, even though many of us here have the scar from the smallpox vaccine because this is extinct. But we get measles and mumps, and we get polio and chickenpox and pneumococcus vaccines. There's even now an Ebola vaccine or the HPV vaccine to prevent cervical cancer. And now there are COVID-19 vaccines. All of these, with a few exceptions, say for rabies, have to be given before the infection occurs. So it prepares the body before you see the pathogen. There are multiple forms. We're talking about a subunit vaccine, not a live vaccine. They can be given once or in multiple cases. So the COVID vaccines, except for the Johnson & Johnson, are given multiple. We have to think about storage and how to measure the response and distribution. We also want to get high uptake of the vaccines by individuals to make a difference on society so we can develop herd immunity. This is where there are enough people vaccinated that someone who cannot get the vaccine is no longer susceptible, and hence they are protected by the herd or the group immunization. And then we want to know, does the vaccine prevent disease? The COVID vaccines do. And do they prevent virus transmission? Those things are under study right now. Do they protect against emerging new virus strains? One of my colleagues is going to talk about this a little bit later. We always look at efficacy and safety for all vaccines and all drugs. If we have, for example, an influenza vaccine that we take every year that's about 70% protective, we say this is a very, very, very good influenza vaccine. The COVID-19 vaccines are made against the spike protein, which is the outside, the red protein here that attaches virus to cells. And there's one portion of the genetic material that encodes this protein. So either that genetic material or the protein is put into vaccines. And we want to know, do the vaccines also affect the new genetic variants that are circulating? So very briefly, here's what has come forth in the US in phase 3 clinical trials. We have Pfizer and BioNTech, which are messenger RNA vaccine, and Moderna. Both of these are approved, as well as the Johnson & Johnson or J&J vaccine for use in the USA. These went through all the normal studies. They were escalated because normally things go from the laboratory through phase 1, phase 2, which takes a couple years, and then phase 3, which can take up to 5 years with about 3,000 people looking at safety and efficacy in a large group. What happened here, because we did not have the luxury of 5 years, the number of people that had to be enrolled was increased, such that over the 4-month time, one can get the same numbers to know the effectiveness of the vaccines as you would over 5 years. And so for Pfizer and Moderna, they had over 30,000 people, and the Johnson & Johnson had almost 60,000 people to get the data necessary to apply for FDA approval. All three of these have now what's called emergency use authorization, meaning that we're in a pandemic, we're in an emergency situation, and it is necessary to do something to prevent people from dying. They are all under surveillance. They all have to apply for licensing by getting other data to show their long-term effects. All right, so here's a video that I don't think I can show you because of the platform that we're on. But this is a video. Let's see if I tap it here. Does it work? All right, so what that just showed you, and I'm going to summarize it here, is that for the COVID-19 vaccines that protect from disease, we're putting in the gene that has the spike protein code. It's the messenger RNA, actually, not even the whole gene. It's put into lipid or fat droplets, like the droplet like Crisco oil or something that we cook with, to protect the messenger RNA. That's what's in the vial, along with water, sugar, and some other buffers. That then is injected into the arm such that those fat droplets carry the encoded RNA for the spike protein to our own cells, where our own protein factories make that protein to go on the outside of our cells. So the gene is not going into our nucleus. As a matter of fact, this genetic material degrades in a couple hours. But our cells are then making this protein that our body recognizes as not us, as something that's not us, and thereby mounts an immune response to it. And so both our all types of our immune system, the one that makes antibodies and the one that makes memory cells, will now respond to the spike protein such that when we see it again on the virus, we are ready to destroy it. The Johnson & Johnson is similar. It's simply using a defective virus carrier, a shell virus, to deliver the spike gene. The same gene is put into another virus such that it allows our own cells to make the spike protein so we can mount an immune response. And it only takes one dose, as well as it seems to have broad usage against multiple variants. So lastly, to summarize the vaccines, we have two messenger RNA vaccines in lipid particles. They both contain material to make the spike protein in our own cells. They're both 2 injections, 21 days or 28 days apart. They're up to 94 to 95% effective in blocking disease after 2 to 3 weeks of both doses. The other vaccine, the Johnson & Johnson, is delivered by a virus taking the spike gene into our cells. It's up to 85% effective in blocking disease with 1 dose. We're still studying the effects of, do the vaccines prevent infection or shedding, and how long does this immunization last? We now know it's at least 6 to 8 months. It may be longer. There are side effects of all 3 vaccines, but they are short-lived, somewhere around 2 to 3 days. And this comes from activating the immune response. This is our body's response that is making us feel bad. Not that we're infected, but that our bodies are working to detect and respond to the foreign material, the messenger RNA spike that's been put in our bodies. Afterwards, we also need to continue to use the masking and distancing because, as I mentioned, we don't know yet about shedding virus from someone who's immunized. You should enroll with VSafe to report, where they will check on you every day for the first week. And then if there are any adverse reactions, you can also report them. You or your health provider or family member can report them to get attention. So in summary, both of these, all 3 vaccines have some pain at the site of injection for some people, and some people have no response whatsoever, no side effects, but others may get pain at the injection site, or headache, or fever, or fatigue, or chills, or muscle aches, or even some other side effects. But these are what you get anytime you get an immunization. For those of you who get a flu shot, this may happen. And again, this is your body's natural response as we set up a host memory defense. So what do we want? We want to build trust to use these preventions that are available to us. We need transparency. We need clear messages, what we're trying to do today. We need equitable access. There are a lot of community pop-up clinics. We need community engagement and investment, which is what the AME Church does so well, what the Health Commission is trying to make happen, so that we can have high buy-in of the vaccines and the preventions that we can protect our population. So in summary, the COVID-19 vaccines block disease and death from coronavirus infection. We have 3 vaccines that are all equally useful as tools in blocking the symptoms of COVID-19, which are listed here. People get different levels of symptoms from nothing to severe illness to death. And all 3 vaccines have been shown to be effective in blocking symptoms, severe illness, and death. If you get any of these symptoms, trouble breathing, persistent pain, confusion, inability to stay awake, or bluish face or lips, you should seek emergency help. When we get the vaccines, we still need to continue masking and distancing and not gathering until we can be sure the level of infection is below 3% in the population. So therefore, the masking and distancing, the things we know to do, are very important. And it's important to wear the masks correctly, cover the mouth and nose at all times to prevent these particles, in case someone's infected, from going into the air and infecting other people. So in the last slide, just a reminder of what those preventions are. Proven preventions: physical distancing 6 or more feet from others, staying home away from other people, or if you're around other people, wearing a mask correctly, limiting the number of gatherings in the reopening. We're here in Michigan and we are seeing a surge right now because it's springtime and people are gathering. And we also have the B117 variant, which you'll hear about. Frequent hand washings, not touching common items and then touching our face. Getting tested if we think we might have been exposed. contact tracing, cooperation, isolation if necessary, and then fortunately, we have now vaccines, 3 vaccines that can help prevent death and disease from COVID-19. So we need to use all the tools in our toolkit to help us break the back of this pandemic. We are all in this together, and we will be happy to hear what you have to say, what your questions are, so we can begin to understand how to get out of this. All right, I'm going to turn it over to my colleagues now. Did I stop showing the screen? Stop screen. There we go. I think Dr. Burnett has something to share with us on the virus variants, and we will be happy to take any questions that you have.
I do. We are going to now talk about all right. Am I unmuted? Great. Wonderful. So we're now going to talk about what we need to know about updates regarding the COVID rates. And if you look at the screen, you will see that the rates are going up slightly. That's new cases. Deaths are going down. That's the good news. Hospitalizations going back up as well. When you look at the actual numbers, the last 7 days are on the right side. These are cumulative on the left. Right side is the last 7 days. The number of deaths has gone down 14.2%. That's wonderful. This is US data. I will get to the global data in just a second. The case incidence, however, has gone up 0.5% to 136.7 per 100,000. The number of tests that are now positive, back up 0.3%. The number of hospital admissions, up 6.9%. The number of people in the ICU, up 3.8%. Those may look like small percentages, but when you look at the actual numbers, they are significant. But the good news is the vaccines must be working. We are seeing that, and that the number of deaths is going down. However, when you look at the accumulation of the community transmission, you see that the community transmission is going back up again. If you look at the United States, the darker the color, the redder the color, the more significant and the higher the rate of transmission. Puerto Rico is a dark red as well. Many of the islands in the Caribbean are dark red, as well as many countries in the on the continent of Africa. Areas concerned, the darker the color, the redder the color. Also, the areas, and they are considered, the dark red is considered sustained hotspots. When you look at the global situation, these are numbers that have come from the World Health Organization. You will notice that the uptick is strong over the week. The curve is going up for both confirmed cases and deaths. If you look at by country, by World Health Organization region, that also is a significant uptick. All you have to do is look at the wave going up. When you look at variance report, we'll now shift to variants. The number of variants that have been verified, where you see blue, that's verified. Where you see green, that's unverified, but somebody reported it. And where the light tan color is, there is no report at all. When we look at variants in the United States, we see an increasing number of different kinds of variants. Some folk have heard me say that I started looking at this on February 9th, 2021, and there were only 3 on this chart. We now see a significant increase in not only the number, but the percentages, and there are now over 200 additional lineages that are in the other category. That was not there back on February the 9th. When we look at the specific, the 3 largest number of variants, well, the 3 ones that they're most concerned about. These are the 3 that we started with on February 9th. 932 on February 9th, as of April 8th, 19,000 for B117. For B1351, February 9th, there were 9 cases in the US, now up to 424. For P1, that's now 434, up from 3. Blue, dark blue, is the update on the concerned areas, areas of concern in the United States for variant B117. It's the same for all 3 slides. The darker the color, the darker the blue, the more cases there are. You will notice the transition from March 22nd over to April 8th. I have also included, and I will put into the chat, the link so you can look. When you click on your state, you can actually see the specific numbers for your state and begin to follow it yourself. But it is just obvious. A picture is worth 1,000 words. Look at the dark blue that is increasingly appearing. Same thing for P1. At one time, there was a lot of clear space. That clear space is dwindling. Same thing for B1351. There was a lot of clear space in the central part of the country, and even in Ohio, West Virginia, etc. You will see now, West Virginia, you see now that there are increasing numbers everywhere. So when we talk about variants, why are they important? The B117 is about 50% increased transmission and likely to cause increased severity of disease. P1 has had a moderate impact on the neutralization that occurs with the monoclonal antibody therapy. B1351, there's a 50% increased transmission rate and a moderate impact on one of the major treatments. B1427, there's about a 20%. Same thing for B1429, 20% increased transmission rate. I first looked at this data on March 16th. I looked at it again this morning, and there is no change in this data despite CDC updating its website on Friday. So what does that mean? It means that we have several questions that we need to understand that we do not presently have answers to. For all of the variants, are we talking about, is it easier to spread? Does it cause milder or more severe disease in people? Those studies are ongoing. They are, at this point, seem to be detected by the currently available viral tests, and the response to medications currently being used is, again, being continued to be studied. And is there a change in the effectiveness of the COVID-19 vaccines? Still being studied. I'm going to skip these slides because I want you all to ask questions. But what is important to us as AMEs is please look, the second bar is the white non-Hispanic. Those of the percentage in red is those who have received at least one vaccine. And the color underneath it, a grayish kind of color, I'm not sure it's how it's showing up on your screen, is the percentage of the US population. So more white non-Hispanic have received the vaccine than their percentage in the United States. When you look at Black non-Hispanic, it is exactly the opposite. Less Black non-Hispanic have received the vaccine than the percentage in the population. Same thing occurs when you look at people that are fully vaccinated at this point. When you look at the global impact and doses per 100 people around the world, the whole center and eastern border of the continent of Africa is without vaccine. That's the, I guess it's pink or gray, depending on what it looks like on your screen. When you look at South America, where we're talking about Brazil and Guyana, etc., where we have AME churches, you will find that even though some are receiving the incidence or the dosage administration is severely impacted. Same for Canada, as well as around the UK. So I'm going to put this in the chat. It is the COVID World Vaccine Tracker. If you just click on it, you will be able to see by country the number of vaccines and watch and see how much of an advocacy moment you need to have in order to help our brothers and sisters around the world. It is, I can't call it anything but astonishing. So what do we need to do? Preventive measures, continue our proper hand washing and or use of alcohol-based hand sanitizers, more than 70%. Keep up healthy habits that boost your immune system. Reverend Mitchum is not with us today because she's at her annual conference, but if she did not, we do not talk about our nutrition, she will not be pleased with us. So you have to eat healthy, you have to exercise, you have to ensure that we are keeping up our rest, our exercise, and attempt to reduce stress. Maintain your vaccine schedule for all of the vaccines that you are age-appropriate vaccines. Now, wear a mask. Wear a mask with 2 or more layers. Wear the mask over your nose and mouth and secure it under your chin. Make sure the mask fits snugly on the sides of your face. Make sure you're still maintaining physical distancing, at least 6 feet away from those who do not live with you. And remember that, again, as Dr. Fuller said, some people without symptoms may be able to spread COVID-19 or flu, even those who have been vaccinated. So this is just a demonstration of how you should wear your mask. Using mask fitters or other nylon covering over your mask will help to improve and limit the spread of virus. I put into the chat copies of the HHS and CDC public education campaign. The Health Commission is a part of the new initiative regarding COVID community promotion that has come out of the HHS office and the White House office is a joint initiative. This is one of those documents. What fully vaccinated people need to know. It is the same information that is coming out of HHS, Health and Human Services, the White House, World Health Organization, CDC, and a variety of our agencies that we are all a part of, whether it be the Association, the American Academy of Pediatrics, the ACP for the internists, AFP for the family practice, et cetera, et cetera. So there are some things that we need to know. When is someone fully vaccinated? 2 weeks after completion of whatever the series, the 2-dose series or the one single dose series. 2 weeks after you've received the last of whatever you're supposed to get. So what can fully vaccinated people do? They can gather indoors with other fully vaccinated people without wearing a mask. And when they do that, if you are gathering indoors with unvaccinated people from one other household without mask, unless any of those people or anyone is at increased risk for severe illness or COVID-19. Let me say that again because I stumbled over the words. You can gather indoors with unvaccinated people from one other household without mask, unless any of those people are at increased risk for severe illness. That's one other household. If you've been around someone who has COVID-19, they do not need to stay away from others or get tested unless developing symptoms. Fully vaccinated people should continue to take steps to protect themselves and others, like wearing a mask, maintaining a distance of 6 feet apart, avoiding crowds and poorly ventilated spaces. Precautions have to be taken whenever a fully vaccinated person is in public, gathering with unvaccinated people from more than one household, visiting an unvaccinated person who is at increased risk or lives with a person who is at increased risk. All right. And these are the links. They are already in your chat. We ask you to stay safe and remain healthy. I am going to stop sharing so we can now begin to look at the chat and begin to answer your questions. Please put your questions in the chat. We can see them on Facebook as well as on Zoom. I am not monitoring the Zoom chat, so please
Okay, I see the first question. If a person receives the vaccine, will this protect from the COVID variants? The answer to that is so far with the variants that we have and the vaccines that we have, there's still protection with the vaccines that we have against the variants that we have. The issue is that if we continue to have variants develop, so when we have variants of our variants, it may be that they will get past the vaccine protections that we have now. The good news with messenger RNA vaccines is we can change the content very easily of those vaccines, but it will mean that people will have to get a booster vaccine. The important thing to remember is that we can shut down the ability of the virus to vary by shutting down its ability to reproduce. Every time it reproduces in anybody's body, that gives it an opportunity to change a little bit. And if that change is good for the virus, remember the survival of the fittest, that virus will rise up to the top, which is why you see all those new variants that Dr. Burnett showed you. So the best thing we can do is shut down the virus by using the vaccines as well as the preventions that we already have had for a while to keep it from people getting infected and making more virus. In the speaker's opinion, does the lack of testing hurting the fight against COVID? I'm going to ask one of our physician colleagues to answer that, please.
Hi, I think the question was, is the lack of testing hurting the fight against COVID? I would say yes, because some persons are asymptomatic with this, or they are delaying going to be tested once they have symptoms under the auspices of that, oh, I think it's just allergies or a cold, or I have GI symptoms, and it should not. And with that, that has increased some of the spread because they are then not quarantined and exposing others to the virus. And as Dr. Fuller has stated, with increased exposure and inoculation of persons, then it has the opportunity to mutate and come into different variants.
I think I would add to that, when we started the fight against COVID-19, we started on a 3-prong. It was testing. Testing was going to drive tracing. Tracing was going to drive treatment, as well as take care. So the testing is still definitely the driver for the other components. So it is still highly recommended that if people believe they have been exposed to someone with COVID-19 positivity, or they are, or they believe, whether they express symptoms or not, we do need testing throughout. There is a big push for vaccination, but we still have to maintain this 3-tier approach. You got to test, you got to trace contacts, you got to treat. Now we have the vaccine coming into that model, as well as take care, meaning we still have to provide services for those who may need to isolate or quarantine during their time of exposure or their infectious period. We still have to be able to offer people the ability to isolate in hotels, to get food delivered, to get medication delivered, so they can remain in isolation or quarantine.
All right.
Why is the wave of COVID going up globally?
We can't hear you.
The question. Oh, God.
The question was, why is the trend going up globally?
Yes.
Okay. Some of that has to do with the variants. As the number of variants increases, and I'm going to ask Dr. Fuller to add to this. As the number of variants increases, and you saw that I said that the transmission rate is about 50% higher with the variants. In addition to that, we are beginning to experience COVID fatigue, and people want to go without their masks, begin to gather more, moving around more than would be normal. And so we are seeing numbers go up. The other piece is the dissemination of vaccines across the globe. You saw the map, is slow and or poor. So all of those factors play a role. Dr. Fuller, if you will speak more to the variants, that would be helpful.
Yes, I think you covered it. There are a couple of reasons, as was just mentioned, but one of the main ones is that it's springtime, at least in the Northern Hemisphere, and people want to get out. We want to engage. I'm thinking of someone in my Payne Seminary class who had just finished the COVID, had just gotten his first vaccine, and ended up as a DJ at a major event with over 200 people. A couple of days later, he had symptoms of COVID, got tested, he had coronavirus because his vaccine had not yet gone into effect. It had not been 2 weeks. And so we're just social people that want to get together. And it's so easy with better weather here or even in the Southern Hemisphere to want to be in touch with family and friends. And yet this virus is so easily spread. I would ask you to go to some of the animations, which links are in the chat, which show how easy the virus floats through the air. And so if you are anywhere and you breathe in that with somebody who doesn't know that they're infected, who doesn't have a mask on, it's very easy to get infected. If you have a variant that's now 50% higher in its ability to transmit, just imagine what it took an hour or half an hour for you to be in somebody's presence that was producing virus. Now you can get virus in to cause enough infection in 10 minutes or 15 minutes. That's what 50% more transmissible means. So we need to race faster than the virus changes in order to break the back of this pandemic. And that's why we're hoping that people get vaccinated and that we remain diligent in using the tools that we know, the vaccine, the preventions, the masking, the distancing, the not gathering, except under the regulations set forth for vaccinated people.
If a fully vaccinated person can still transmit the virus to others, why are fully vaccinated persons still able to attend gatherings without wearing a mask, especially where unvaccinated persons may be in attendance? I think the key thing in Dr. Burnett's presentation that she highlighted when she spoke about fully vaccinating people being able to not wear masks around other fully vaccinated people, the key word there was one other household. The HHS and our Surgeons General still does not recommend that fully vaccinated people attend medium to large gatherings. So that was the key in her presentation, was one other. And now my other colleagues can add in questions.
Yes, we don't know if people are shedding virus even after they get vaccinated. So that's another reason to not be around a large number of people, because if anyone's shedding, then that means that there's more virus in the air that can get into anybody who's unvaccinated or vulnerable. And thereby we're allowing the virus to reproduce again. I'll just stop it there. I think Dr. Collins was about to say something.
Hi, I think on here they were saying about vaccinated people being in gatherings with without a mask with unvaccinated persons in attendance. That is not recommended. That's not what is recommended. So I think there was some looking at the question, some confusion from the person asking. So it's not recommended, as been previously stated, that that they're medium or large gatherings with vaccinated persons or unvaccinated. The answer is that if you have been vaccinated and everyone in your household has been vaccinated, that you could gather with one other household of fully vaccinated persons. So that would mean that everyone in attendance has been vaccinated and waited the 2 weeks after their second vaccination to be considered fully vaccinated to be in attendance in that one small gathering.
What are your recommendations for those who will be attending the general conference if they have been vaccinated? We can take this one by one.
Okay.
The general conference is considered to be a large gathering. And according to the HHS, according to the CDC, fully vaccinated people should not be attending medium to large gatherings. And as we said before, when you are fully vaccinated, you still have to maintain physical distancing. You still have to wear a mask. You still have to follow the washing hands and hygiene protocol. So being fully vaccinated in a large gathering is not recommended. But if you do decide to attend a large gathering and you're fully vaccinated, the expectation is that you still have to maintain the other guidelines.
And one of the reasons for that is because we want to model what everyone should do to be safe. Not everyone's able to get the vaccine yet. I don't know that by July how many people will be vaccinated. Maybe that number will be up near 90%. But even so, it's very important to model what will help keep everybody safe. I think it was Dr. King that says we have to live together as brothers and sisters. So we have to model, we have to be our neighbor's keeper in order to make sure that our neighbor is protected and we do the things that will help those who cannot, who are most vulnerable. So that's another reason. We don't want virus circulating. Remember, we also don't know if a vaccinated person is protected against infection. We know they're protected against disease symptoms, which was what was used to screen the vaccines. But we do not, the studies are still underway to ask if infection and shedding is shut down completely in someone who's vaccinated. So if it doesn't make you sick or symptoms, that's great. But you don't want to be shedding virus that could go to somebody else or even reproduce in somebody else to lead to a new variant.
So my answer to the question, what is your recommendations for those who will be attending the general conference if they have been vaccinated? My answer is don't go. Point blank and simple. It is not going in line with the CDC guidelines. It is a large gathering by definition, even if you have decreased the number of persons in attendance. It is a large gathering. You are still gathering persons from more than one household, regardless if you separate them out by state. It is still a large gathering and is not recommended by the guidelines. So my recommendation is that you don't go. If I think there's a second question, is there a plan in place or if there's a huge outbreak? I think that question is going to be best answered by your General Conference Commission. Again, it's a large gathering and it's not recommended. And we know that the conference center is not doing contact tracing. So, and you can go to their website to take a look further at that.
The other thing I want to add, not only is it a large gathering, but it is a large, predominantly indoor gathering under a central HVAC system. So that brings other factors into the gathering. It is indoors, and the recommendations are that if you can gather in small groups, it should be outdoor. So this is a large gathering, majority indoor, with people from different states, different households, possibly different countries, if our global sisters and brothers are even allowed to travel to the general conference. So that is not recommended. And many of you know that we, as the International Health Commission, has taken the stance to not be in attendance, but we do know that the General Conference Commission has hired Orange County Health. So those questions in regards to outbreaks, in regards to what the plans are being put in place would be best addressed to the General Conference Commission as to how Orange Health will handle those situations if needed.
Bishop Leith has placed a question in the chat that asks, on the basis of the chart on variants, it appears South Africa is a hot spot. So if we urge all Africans to go to a meeting in Joburg or Cape Town, are we inviting them to a hot spot? The answer to that is it's a hot spot.
Yeah.
Yes.
So, are there other questions? I see none others. We've answered that one already. Are there any? I'm looking at Zoom to see if I see any in the Zoom. I do not.
Dr. Burnett, while you are looking for questions, I just want to make a statement about end game with this pandemic. I know that we all want to get to the end of this. This is the desire of everybody. What does the end game look like? So we're going to coexist with COVID-19 like we coexist probably with influenza and some other things. Right now in Michigan, we are at an 18% testing rate, positive rate. So that means that about every 100 tests, 18 are positive. And we have the B117 variant circulating here, as you saw. It was brought back from Great Britain back in January. So it got an early start in Michigan, even with all the mitigations. And so what we need to do is do everything we can collectively, vaccinations, not gathering, masking up, doing those things we know to do to get the testing level below 5 to 3%. When only 3 to 5% of the tests in a given area are positive, that means that the virus is not circulating at a level that people are getting infected. And that means it's going to be safe to get together for a barbecue in the backyard. It's going to be safe perhaps to have our children in school and play sports. Right now, sports have been asked not to occur in the high schools in Michigan because we're at that high 18% rate. So what does it mean? It means that there may be times if we work together to keep the virus low and do those things that we know work, that we can coexist with vaccinated people, even with variants occurring, to keep COVID-19 and coronavirus at bay and in place like we do pretty much with influenza. If we don't do those things, and if we don't do them together, if some people do them and some other people don't, then we're still going to have these surges and fluctuations, and we will all be at the risk of not getting to a new end game where we can coexist and where our hospitals can handle other medical, normal, typical medical situations other than being very highly populated handling the coronavirus. So this is what we're trying to get to, and we need everybody. Everybody needs to be involved in this. Unless God does another kind of miracle, which is possible, God can do anything, then we have been given ways to handle this pandemic. The question is, will we hear and will we be obedient? Or will we be so set on doing things our way, the way we've always done them? My daughter wants to come over, so yeah, come on over. Or I want to get together with some friends for a dinner inside, or I don't want to cook, so let's go out to the restaurant. If we continue to do what we want, then coronavirus is going to be around. If we follow what we've been given, what we understand from science and medicine, then I believe that we'll be able to manage this pandemic. We'll be able to get those percentages down below 5 and 3% of people testing, and only have to mask up or do things when the level go up. Otherwise, we'll be able to handle it by contact tracing, by isolation of anybody that gets infected. And this is our goal. This is what we want to get to in lieu of a major miracle where coronavirus is just wiped out. If that happens, I think we'll all rejoice. But until it does, we have been given things to do. And the question is, will we do those? Or will we insist upon having our own way individually, which keeps us all in a situation where COVID is here?
There are two more questions. One is, if you have a history of blood clots, should you not get a particular vaccine?
That's a physician question.
Dr. Collins?
No. Blood clots are a large part of COVID-19. And so you have a hypercoagulable state when persons have coronavirus, meaning that they're at an increased risk of getting blood clots to the brain, causing strokes, blood clots to the lungs, causing pulmonary embolisms, blood clots to the heart, even smaller blood clots to extremities and digits, where amputations and those things have had to occur, and so decreased flow. So if you have a history of blood clots, then you would be more likely to have greater issues if you were to develop coronavirus. So I think getting a vaccine would be proactive in that situation. And of course, you can speak with your physician or your hematologist more about that. But I think that it would be more beneficial for you to get a vaccine than for you to not.
The next question in the chat is, at this point, are we at a place to start looking at additional levels of indoor worship for small to medium-sized churches? I believe we've kind of already answered that question.
I think.
Go ahead.
We can't hear you, Reverend Dr.
Yes.
Fuller.
I'm
There we
sorry, I
go.
didn't, the old thing, unmute before you speak, right? So until we are below that 5 to 3% level of positive tests on a regular basis, I am sure that the overall recommendation is that we do not gather even in our churches, which are closed in spaces with people who have underlying conditions. And so again, the target is 5 to 3% of positive cases coming back, meaning that it is safe now to get together.
And as a pastor of what I would consider a small to medium-sized congregation, what I have charged pastors who have reached out to me to do is look at the infection rate within the community where your church is located. My church is located in Bedford-Stuyvesant, Brooklyn. Its infectious rate right now is hanging around to 6 to 7%. In addition, that we have a small percentage of our community that are fully vaccinated, and even smaller percentage of our community that has only received 1 dose. So for those of you who are pastoring, look at the data for your particular area. And right now, I can probably assure you that the data shows that we are not ready to enter back into our churches.
And you can refer to that link that I highlighted earlier, where it was a picture of in the U.S. districts 1 through 13. You can click, and actually it had some of the 16th in it as well. You can click on it and go drill down to your state level. If you go to your state public health department, you can drill down to your county level, and on some state health department websites, you can drill down to zip code. I know in Pennsylvania and Georgia, which are the 2 states that I look at the most, though you can drill down to your local zip code. So it suggests that you follow the recommendation just made by Dr. Williamson, because I can completely concur that one needs to know where they are in their specific area.
There's a question, is getting a vaccine recommended for pregnant or lactating women? Dr. Collins, would you like to address that one?
Yes, it is recommended. And of course, you can always speak with your obstetrician, but there's also some benefits that are in with lactating women, especially with providing some protection to the baby that is breastfeeding. So at this point, we do recommend that pregnant women receive the vaccine, as well as that they receive the flu shot. Again, speaking with your obstetrician with this and going over the pros, cons, and risks for your specific situation would also be warranted.
And I just want to quickly take this brief opportunity to mention our pediatric populations. Currently, the only vaccine that has been authorized to address pediatrics is Pfizer, which begins at age 16. We do know on this past Friday that Pfizer did ask the FDA to expand their emergency use authorization to include ages 12 to 15. But since children make up anywhere from 22 to 25% of the US population, that targeted herd immunity, where people are anticipating that if we get 80% of our population vaccinated, the herd will protect those who are unvaccinated. We are not going to reach herd immunity until children are vaccinated. Currently, we have seen a rise over the past 2 weeks from around March 25th to April 1st, where the new cases, pediatric cases, have been increased between March 25th and April 1st to 64,000 new cases. Of those pediatric cases, we are seeing that a good portion is being caused by the UK variant. We are also seeing that even though there's a large number of new cases, their hospitalization rates are still hanging around 1 to 3%. So all three of the current vaccine makers, Moderna, Pfizer, and Johnson & Johnson, has started their pediatric trials. I know Pfizer, in making this request, is anticipating that a lot of our school districts come this fall are planning to go back to full 5-day in-person instruction. As a matter of fact, here in New York, we do have some school districts as of April 5th that already have opened their doors for 5 days of in-school instruction. The basic thing, and this could be a webinar all by itself, is that as parents, educators, we have to begin to look. We know that the CDC dropped the guidelines down to 3 feet apart as opposed to 6 feet. But the caveat for that is that the infection rate of the community where the school is located should be under 1%. So, for that 3 feet, it is not a blanket rule. You still have to know the infection rate of your community. So majority of school systems, especially in New York, because we are in a surge, we are in an uptick, I still have to maintain that 6 feet. So just, as we go towards the fall and the reopening of schools, a lot of these vaccine companies are hoping to have vaccines available for children under 16. And it looks like Pfizer might be the first one to expand it to 12 and 15-year-olds.
Dr. Fuller, this next one comes to you or Dr. Collins, whichever is the preference. I'm 82 years old and I had absolutely no reaction to my first and second shots of the Pfizer vaccine. I have read that's okay, but would like confirmation.
This is absolute confirmation. That is okay. As a matter of fact, in the studies, again, the side effects, which last for, usually they're done by the 3rd day. People say they wake up. Even my niece, who is in her 30s and has 3 children and is a care provider, got the vaccine, and she said she just had chills and fevers the first day. She woke up in a sweat the night after she took it. The 3rd day she woke up and was like, Auntie, everything was gone. I was back to me. So what happens is that the immune system is responding, and the more robust your immune system, the more likely you are to feel the side effects. So at 82, you probably aren't going to feel them. And as a matter of fact, that's what was said in the clinical trials, that the lesser side effects were seen the older you were. And so this is confirmation that you are immune, your immune system is working, and because you didn't have any side effects, that is good. That is a good thing. So you should be fine.
Dr. Fuller, I have been asked several different times that I don't see this question in the chat, but I'm going to ask you for clarification so that when I speak with sound voice. The question has been, how long does the immunity last?
Ah, I wish you'd asked me something I know.
Well, my
That
answer has been we don't know that information yet because the studies have not been completed. But
ye-
let's have the virologist say that.
well, that was asked at the FDA panel as well, and the answer is just what you're saying. We don't know yet. Those remember that these are clinical trials. This is an emergency use authorization. Studies are ongoing, which is why it's important that you do the be safe to give your responses, your effects to the CDC to go into the database. But we don't know how long. Now, right now, the last I saw was that the vaccine immunity is lasting at least 6 months. So some of the people who've been in the study for that long are still protected at the end of 6 months. And I did a webinar with a group in Detroit just this past week where a group of Black skiers got exposed and many of them got COVID in late February of 2020. And one of them, the president, told me that she and her doctor followed her antibodies. She's gotten the vaccine now, but in January, before she got the vaccine, she still had antibodies to COVID. Now, were they protective? We don't know, but that means that immune response for her had lasted 10 months at least. And I don't know if it's still there, but she did get the vaccine. So we don't know the answer to that, and the studies are ongoing to try to answer them. But even if just for a little while, if for 6 months, preventing the deaths and loss that we've seen, remember we've had over 500,000 people just in the US to lose their lives to COVID-19. And that doesn't take into account all the people who've been ill and recovered and have their jobs affected and their ability to function to be affected. So a vaccine that can help stop that, even for a little while, is better than the alternative. And I'm just going to take the time here to say that in 3 to 5 years, all of us are going to have some immunity to coronavirus too. We're either going to get it by getting exposed to the virus and surviving, hopefully, or if we don't survive, we won't be here it won't matter, but we'll have some immunity from exposure and recovery. And that still may leave some long-term effects, or it may leave none, or it may be asymptomatic. We don't know. Or we can have immunity that's purposeful to the spike protein. And what I like to tell people is that when you get infected, it's like you get the virus, which I use my fists with all 5 fingers as an example. And we get immunity to all of this, and some of it's protective. When we get the vaccine, we're getting immunity to just the spike, just the thumb portion, which is used to attach the virus to cells. It's a critical piece for the virus to be able to get in cells. So it's highly protective because it's specific. And that is even a greater protection than the natural infection. So we're either going to be immune because we got COVID infected, survived it, or we're going to be immune because we got one of the 3 vaccines. And so I personally got one of the vaccines, and for me, that was the best choice. You're going to have to make your own choice. The more underlying conditions you have, also, the greater the danger of severe disease from coronavirus infection. So someone else who I worked with has a heart condition, and he hosts a podcast, and he hadn't gotten a vaccine. And he said, well, I have a heart condition and da 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 da. And I said, well, gee whiz, you should get a vaccine. He says, well, wait a minute. Are you telling me I should be at the head of the line because I do have underlying conditions? I'm like, yeah, I'm telling you, you should be at the front of the line because if you get exposed to virus, your body has less of a chance of fighting it off than someone who doesn't have any underlying conditions. And that's what our health departments have seen. They're putting the vaccines, at least in Michigan, in the communities that are most vulnerable. So I just want to share that with people so you understand that there's some things we don't know about these vaccines, but we know a lot. And what we do know is that they are a wonderful tool to help us avoid being ill and continuing to pass this virus around.
And I would just want
Go ahead.
to piggyback and say we are still facing major challenges in our Black and Brown communities with vaccine hesitancy and mistrust of the medical system. So as houses of worship, people of faith, we play a big role in getting information out to the communities, to our communities, to help them get over, their vaccine hesitancy, and to build trust. And building trust in the medical system is multifactorial. But our biggest fight against this, in addition to the vaccines, is education. And that is what we're doing here today. We are bringing you the facts. We are bringing you up-to-date information, but we still have ways to go in our Black and Brown communities. As you saw, the percentage is low. We're hanging around 8%, where our white counterparts are at 65%. So we still have work to do to get the information out to our people.
The last question that I see at this point is getting, nope, wrong. What about people with allergies or autoimmune issues like lupus or MS? I'll take the allergy one. It is recommended that if you have an allergy to a specific ingredient in one of the vaccines, then one, you need to consult an allergist or immunologist and have that conversation with your primary care physician or other provider. If you do not have one, let us please take the opportunity at this point to tell you to get one. In addition to that, we need to ensure that you hold conversations that are very targeted and in depth. The next thing about allergies, if you have allergies, seasonal allergies, allergies to food or latex or anything like that, you are eligible to get the vaccine. If you are uncomfortable, again, hold a conversation with your primary care or the person administering your vaccine. In addition to that, instead of only 15 minutes of observation, it'll be 30 minutes of observation. I have a severe nut allergy. I'm allergic to every tree nut known to man. And I got both vaccines and did not have an allergic reaction, just as they said I wouldn't. So I'm a testimony to it's okay. But you should have a conversation if you are uncomfortable. But CDC, as well as all of the other entities, have said, do not hesitate if you do not have a specific allergy to one of the ingredients in the vaccine. PEG, polysorbate are the number 1 and 2 that you need to consider. As it relates to lupus and MS, Dr. Collins?
So far as autoimmune disorders, on this one, a lot of times I really have people punt that to their specialist. But I will say that if you have an autoimmune disease, lupus, MS, and because of some of the things that go along with it, you're certainly at an increased risk for a poor outcome if you develop COVID-19. And for that reason, I would recommend that you are vaccinated unless there's a specific reason given to you by your physician. And I'll kind of punt that over to Dr. Fuller for a little bit more.
Okay, well, this is a question that again, we don't know that there's anything in the vaccine that will enhance autoimmunity. This is an area that is certainly under study, but the danger of COVID is much greater, as we know, than the danger of the vaccine. So as has said, if you are under a medical care and you have your lupus and MS under control with your health provider's input and advice, it would seem to be wise to get a vaccine to prevent getting COVID, which we know can be very detrimental on anybody who has any differences in their overall health. But again, I would agree that you really want to talk to your health provider about that. That goes with sickle cell, any of those underlying conditions that affect the overall immune system.
I do not see any other questions on
There's just
Zoom.
one more question.
Here's one more. Okay.
Are these vaccines okay for us? They were developed so quickly, a year.
Dr. Fuller, that's you.
Yes, so that's the question we hear often, and most vaccines, as hopefully you saw in the PowerPoint, take anywhere from 3 to 5 to 10 years. This technology, even though we've never had it in a human vaccine before, it's been around. It's been used in animals. It's been used for cancer treatment delivery to humans. And so what happened was these vaccines went through every step necessary in order to assure effectiveness and safety, except for the long-term 5-year out period because we're in an emergency. So what happened, I'll give the analogy, if all 5 of us on this webinar were making a quilt and we were going to all make a quilt, each of us were working on our square and we were going to complete our own quilt. Well, because there was a real pressing need, we came together and put our square patterns together and just reproduced our own pattern, but put our pieces together to make the quilt. We would get a quilt much faster. And that's exactly what happened in the scientific community. The government paid for the funds to, or supplied the funds to do this up front, even without knowing if the vaccines will work. People brought the messenger RNA technology, they brought the lipid particle technology, they brought the clinical trial recruitment. All of those things were done cooperatively, which allowed us to get to a product that is really a feat of the scientific community in less than a year from the time the sequence was known in January of 2020 to having approved vaccines by the end of the year. So it's a miracle. It's something that human beings, like landing on the moon, should be very proud of. And they have not skipped a step in the development of these vaccines. And I was a little skeptical at the beginning, but I'm confident because we see that the rollout of the vaccines into millions of people, the results are very similar to what was in the clinical trials for all 3. So I'm very happy to see that outcome, that nothing new has come up in the millions of people. There have been some deaths, but they're deaths. If you're going to have millions of people getting something, there are going to be deaths among those people. That doesn't mean they're associated or caused by the vaccine. So you'll hear people say, oh, people got the vaccine and they died. Well, maybe those people were on their way anyway, even if they hadn't gotten the vaccine. So there's no causative agent. So you have to be really careful, as they say, wise as a serpent and harmless as a dove in interpreting information that's sent to you if you don't know the source. So I think that's my answer to that question.
To our chemist, if there is another shortage of disinfectants, we're in wave 4. What are the alternatives? What do our people do?
There are household remedies that you can use. One is Dawn and vinegar. 2 parts vinegar, 1 part Dawn. It is the best cleaner for your house, period. It cleans, it disinfects, it cuts grease, but it also will cut bacteria and aerosols. You can take your rubbing alcohol and put it in a pack of baby wipes for disinfectant wipes if you need it. If you have some baby wipes, or you can get some just regular wipes and put rubbing alcohol. It has a concentration of 80% or more. That is a simple cleaner. You normally have Clorox in your house. You can break down the Clorox and use it. Clorox is usually broken down to a 25% concentration. But those are simple things that you normally already have in your house that work great.
Thank you. Anybody see any other questions? All right. On behalf of Bishop Seawright and Reverend Natalie Mitchum, our executive director, and myself, the medical director, I thank you all for all that you have done over this past 14 months almost, or more. It's been a long haul, and I want to thank you for everything that you all are doing to help make sure that we are maintained. In the future, we will be adding more and more conversations about maintaining our health from a collective standpoint. We're going to start revisiting the other topics: heart disease, diabetes, sickle cell. We're still doing Alzheimer's and other dementias. Those kinds of things are going to start coming to the forefront again, because one of the things we do know is that we have to maintain our overall health in order to deal with this and any other of the emerging microbes that are out there, and potentially increasing in number. If we are healthy from all standpoints, we'll be better. We are also going to be looking at the variety of cancers. We'll be honing in on our men and prostate health. Those are starting to come. We are starting to revisit those and develop those. The International Health Commission quadrennial meeting is June 25th and 26th. We are hopefully going to be offering continuing medical education and continuing education units. June 25th and 26th, I said that. And so we will also be holding our official meeting. This is the meeting that was postponed. We normally meet just before the general conference. So the July 2020 meeting did not happen. And so we do need to go ahead and conduct some business, as well as that is normally our time for our training. So we will be doing it June 25th and 26th. Those who are interested in farm and gardening, we have a collaborative partnership with the Black Farm Network. That meeting actually will begin in 20 minutes. For those who've been sitting down too long, we need you to take these next 20 minutes and go take a walk. Because one of the things we do know about walk or exercise your arms, etc., do something, some level of exercise, because we have been sitting, some of us for an hour and a half, for 2 hours. And if you came straight from worship to here, it's even longer. So you need to get up and move, or sit in your chair and move. Please pay attention for all of the updates for all of these, not only webinars, town halls, but information that you can obtain from the Health Commission on amechealth.org, our YouTube channel, our Facebook page is updated multiple times a day. Please access all of that information. I can think of nothing else at this point other than a closing prayer. Right?
All right. If my colleagues are all clear, then is everybody good? It's time to go. All right, let us just bow our heads. Gracious God, our Creator, we just thank you now for what has occurred in the last hours, and we thank you for those who have brought it. We thank you for those who have heard it. We pray that the instructions from you to our people, from wherever it comes, Lord, will be heard through the Holy Spirit, and that we will have the wisdom to do what you are asking us to do for such a time as this. Bless every home under the sound of our voice. Now to you be all dominion, power, and glory forever and ever. In the mighty resurrected name of Jesus, we ask it, believing and receiving. Amen. God bless you.
Amen. Look for all of the rest of the virtual work that we will be doing. Amen.